record this meeting. Okay, so just to let you all know that we're recording as of now, and I'll tell you a little bit about how we can make the recording available afterwards when we get to the end. We'll have the recording available for specific people for a limited amount of time if people missed the talk and they want to get it. So, without further ado, let's get to the cool bit. It was an absolute pleasure to introduce Jackie. So I will make a couple of the routine introductory remarks. So Jackie is an advanced practice physio at UCL NHS Trust. She works as part of a multidisciplinary inpatient pain team based in a tertiary care hospital, but working across lots of different specialties, as well as primary, secondary, and community care. She's an independent prescriber, and in this context, she is a clinical researcher. So she's in the third year of her DPhil at the University of Oxford. She is in the Nuffield Department of Primary Healthcare Sciences, and she is in receipt of the very competitive and prestigious NAHR Clinical Doctoral Research Fellowship. So Jackie's research is focused on understanding how self-management is understood and enacted by people living with chronic pain, and then about how they are supported in policy and practice. And she uses mixed qualitative methods, and I think she's going to tell us all about that now. So, absolute pleasure to introduce Jackie.
Thank you very much for that very glowing introduction. I am going to do that awkward thing where I start sharing my screen. And hang on, where has it gone? Our tech test didn't quite work. Hang on. One more time. There we go. And I shall start my slideshow. Is that clear to you? A nod, Jeremy? Brilliant. Okay, so the title of my talk today is a little bit of a cheat, mainly because it's looking at this idea of self-management, which is quite common to most of us, I'm sure, if we're working clinically. And it's really a little bit of a journey that I'd like to take you through, where I'm going to talk about some of my own research and how I came into this kind of area. But just to start off with my my conflicts in the beginning and front loading that, like those are my funders. So NIHR is my funder. I'm employed by the University College London Hospitals, and I am doing my DPhil, as Jeremy said, at the Department of Primary Healthcare Sciences. And these are not their views, as we all know. And if anyone wants to get in touch with me, you can do via my Twitter handle, which I occasionally do check. But just starting off then, I plan to discuss how I came to start thinking about self-management in this way, and how I planned my studies, starting off about 6 years ago, and really focusing down then into where this phrase self-management came from when we're talking about chronic pain, and then going into a bit more detail about how self-management is understood. And this is through my own work, looking at policy, practice, and the academic literature. And what I'd like to do then is pause and open up the discussion to really understand about responses to the talk, obviously, but also other ways of knowing pain management, which is a really vague way of, I hope to kind of get to through the talk. And I'd also like to kind of hear what is missing in terms of how we think about pain management more broadly. So really, for me, this idea of self-management, which I had really assumed to be a given. I worked with it all the time. I have seen patients for over 17 years, and I thought I was very comfortable with it. But really started hitting a few roadblocks when it came to describing what I meant by self-management if asked by somebody else. And so this was the beginning of my journey into really thinking about what we do with self-management more broadly. So just to give you a bit of a taster, so I worked as a physiotherapist in standard, as we say, musculoskeletal services. And I would say that prior to working there, I honestly never used the term self-management. We used other descriptors, but never really self-management. And my memory was of starting with when we first went to electronic health records, and our digital templates had a phrase, and the phrase was, "We are discharging so and so back into your care as they are successfully self-managing." And that used to be the ultimate goal. You really wanted people to be successfully managing, and then you wrote a little note to the GP or the referrer saying, should they come back to see you, please refer them back to their self-management skills. Don't really interrogate that any further than that, but it certainly became something we talked about a lot more. And then further on, when we started working in pain management programs or group programs, at some point there was a shift in speaking about pain management programs, and suddenly we started to use the phrase self-management more often. I'm not sure that that was ever fully unpacked, but that's certainly the way things were. And then in my current role, what I started to notice was in multidisciplinary team discussions, my medical colleagues would sometimes refer to the work that psychologists and physios and OTs did as the self-management approach. So it almost separated what the medics did versus what everybody else did, to the extent that that's how they described it to patients. And in our outpatient department, I'm sure it's very similar to where you are. We hold these big sessions for patients to come in where they opt in to the services. And at that point, self-management is definitely sold as an intervention. It's not always unpacked. This was just me doing my own initial observations, but certainly that's kind of where I landed. And so this really is where I started to think about doing some research into better understanding what self-management meant in all of these arenas. Now, I don't want to preach the converted, but our standard data, we know chronic pain is a bit of a problem. So I'll just talk you through this little mini infographic because it really outlines my route to my research questions. So we know that lots and lots of people in the world, and specifically in the UK, estimated about 28 million living with chronic pain. Definitions vary, but really we're talking about pain that persists for longer than expected. Now, of that 28 million, of course, not all of those people would classify themselves as patients. So we would say that they're perhaps self-managing well, with low levels of disability and high functioning. So they're out in the world, include probably a few of us in this meeting, and they've achieved this thing, that the holy grail of recovery and rehabilitation. Now, another huge number of people are treated within different parts of the National Health Service and in social care. They might be in different parts of different specialities such as orthopedics, rheumatology, etc. Again, this is not the group of people we tend to see, because the assumption is that they get treated, they get better, and off they go out into the world again. So we're looking at around then that 14% that Fayez and his group kind of talked about when they said these people have higher levels of disability, and they are supposed to be seen in a pain clinic or a multidisciplinary pain service. And within that, the recommendation from a lot of guidelines, and certainly from the British Pain Society and IASP, is to go on to a pain management program where they kind of gain these skills that are now labeled self-management skills. But we know that the numbers that really get through to pain clinics, let alone pain management programs, are really not that great. We've got high attrition from pain management programs, up mostly around the 50% mark, and a bit better depending on where you are and how hard the service works to retain people. So my idea initially was to try and understand all these other people, what are they doing without specialist support? So if they drop out, or they're not keen, or they don't even get a look in, what does their kind of life look like? And to do that, I kind of started, shaping my own research. So the first part of that is really nothing to do with chronic pain. Is I tried to kind of understand what is self-management and where does that come from? And a lot of this work has obviously dovetailed from the work in chronic illness. And this is where I spend a little bit of my time. And I did something called an interpretive policy analysis, which is really tracing the emergence of an idea through time, focused on policy, and really trying to understand at what point that dovetails into what's happening in practice. And to do that, I'm going to do a little bit of multitasking here. I've got a little timeline that I'd like to take you through, but just to make sure I get it right, I'm going to also read, so apologies for that. So looking at health policy in the UK, self-management really wasn't a thing until around 1999, when the chief medical officer at the time committed to a self-management program to address the needs of people with disability. So since the early 2000s, the health policy has actively promoted the role of the active patient in managing their chronic illness. So self-management, as it were, or self-care, has been a cornerstone of UK health policy, and that has been through multiple documents through this time. It's recommended as a part of overall management of many long-term conditions. So the emphasis on self-management can be traced back to the NHS plan, which you may be familiar with, which was published in the year 2000. And this included a commitment to provide information, services, and support to individuals. And they couched this as in relation to health promotion, disease prevention, self-care, rehabilitation, and aftercare. Now, this commitment has been reinforced in subsequent policies, including, in 2007, we had the NHS's social care long-term conditions model, which highlighted self-management as integral to improving services for people with long-term conditions. And then in 2014, the 5-year forward view included an explicit goal to empower patients by investing in group-based education. And more recently, the NHS long-term plan extended this commitment to self-management. And none of these documents really provide a definition or a description of self-management. That's something that I have brought into the interpretation as part of my interpretive policy analysis. Now, they all seem to take the orthodox view of patients as relatively passive recipients of information that is generated by experts. And so what we tried to understand really was, in 2001, something slightly different happened, and this is where we have that dovetailing with broader policy, because in 2001, I'm not sure if you're familiar with Kate Lorig, so she is a researcher and a very successful one who really came up with this thing called the expert patient, in the US, it's called the Chronic Disease Self-Management Plan. And that really was a hugely successful health education and behavior change model for multiple long-term conditions delivered in the community, either by a single healthcare professional as a facilitator or by specially trained lay people. And loads of positive evaluation coming from Kate Lorig's work and her team. And what seems to have happened was, around 2001, somebody from UK Health Policy visited the US and really came back with this as an idea that they wanted to endorse fully in the NHS. And that's when we start seeing this description of the expert patient program. Now, the expert patient program in the UK was different from the US context, mainly because in the US, it was embedded within a wider system of case management within their health HMOs, which I think are health management organizations, and with very specific paying systems. So moved over to the UK with our NHS tax-funded system, it really was a different beast altogether, because this really involved individuals, experts by experience, delivering set manuals of information here in the UK. So that's just a little bit of history about what happened at that point. Unfortunately, when translated to a UK context, the evaluations were a little bit lackluster. So what we have here is These are really key people in this area. So Wright, Barlow and Newbold were really evaluating this kind of work. And what they found was when brought over to the UK, there was really little or no moderate changes versus what the much more glowing reviews in the US findings. They had difficulties recruiting to these programs. They were often underutilized. They had very low numbers of men attending them, low numbers of people who were non-English speakers or people with lower levels of literacy, and people with lower levels of privilege and deprivation were also not making use of these services. So in terms of a social health system, it didn't do very well. And the long-term benefits were limited. So really, to summarize some of these critics here, that the health inequalities might increase because of the skewed uptake of these programs, and the proponents and the advocates for the approach, mainly from the policy side, may have overstated the benefits. And really this idea that self-management support cannot begin and end with a class, and this was really by the chronic care model architects from Kaiser Permanente, where this model kind of originated. And they kind of said that we do need a whole systems perspective where we're focusing not just on the patient, but the professional and the structural issues such as access to services. And that self-care and self-management are often conflated without really describing what the kind of context of what people mean. And one of the key criticisms is that the practices had been appropriated by healthcare professionals and turned into a healthcare intervention, which is really interesting. So this takes me on to like the next stage of what I wanted to talk about here. And it's this, so how did it come into chronic pain? Because like I said, we went from a position where we talked about pain management programs, and suddenly we talk about self-management within pain management programs and self-management of chronic pain as a very standard thing. So I did that thing that everybody does, and I Googled it. So maybe here is a moment to pause, and before I give you my kind of thoughts, it would be interesting to know what you think. If you just maybe stick that in the chat, I'll mind your chat later. Really trying to understand, what is self-management to you, right? So my Google Scholar search was not good, because I regularly do this. I just kind of type the appropriate phrases into Google, and this is like over 2.8 million results. So kind of suggesting that there was no way I was going to do a systematic search of the literature, because this is just too much. So it's obviously very present and very common, highly cited papers were coming up. So that was just the first stage of trying to understand what the scope of this issue was. And then I did something further where I looked at Google Trends, and this is where you look at, so that was the academic community, and this is now the general public. And with Google Trends, you just type in, and it tells you when a search term kind of first got into popularity. And when compared to the 2.8 million results in, I don't know, half a second that we got when we looked at the academic literature, when I looked at self-management as just a search term in Google Trends, barely any hits. So people weren't interested. So in January 2004, this is when they start collecting this data, was the highest peak of this idea of self-management. So that's over on my left-hand side, the blue screen. And every now and then a couple of blips, but you can see the numbers are well below the hundreds. I then tried to focus, what about chronic pain? So chronic pain is a big red button, and you can see that obviously people are interested in pain, and that is something that they're talking about quite a bit. Then I thought maybe it's this thing about persistent pain and chronic pain, and people don't understand it. So I threw that in as well, and that's got even less interest. So something about self-management is something that has been turned into something important in policy. It's important in the academic literature, but in people's lives, that's not necessarily something that has been picked up on using the proxy measure of Google Trends, which is very informal. So my project really is called Chasm, which I came up with before I knew what I was doing, but the idea of chronic pain self-management, and the idea there's a big gap and we don't really know what we're talking about. And this is a mixed method study focused on those who've been excluded from or dropped out of pain management services. And the questions I was interested in was, how have people who have been excluded, how are they achieving, or are they doing this thing that we're calling self-management? And can I make any recommendations to improve practice and policy? And this slide is what I call my DPhil, or my PhD. It's kind of what I had planned to do, and I'm just going to, it just gives you a sense of my methods overall. So the work is split into 3 phases. So looking at different levels of society. So the macro level, looking at policy decision makers, the more overall discourses or narratives about self-management. Then the organizational perspective, which is really about an organizational case study. So looking at the boundaries within which self-management services are delivered and how that is enacted. So this is it's a focus on one, what do you call it, a county, there we go, a county in the UK, and this is in the south of England. And then diving deeper, this is the patient perspective, or the lived experience perspective, which ideally was going to be the huge part of the project. So the idea was to do long-term follow-up and ethnography, or going along and examining people's lived lives of living with pain, and as well as cultural probes, which is just cameras and diaries and different ways for participants to capture their daily lives. Then the pandemic happened, so that has changed a little bit around. So we focused a lot more on the policy context. So I have a lot more data around what's happening in the policy world, and a little bit less about what's happening from the lived experience perspective. But I have now completed phase 3, phase 1, and part of phase 2. And what I'm now doing is that bit at the bottom, which is bringing that data together and trying to look at and pull out these narrative storylines and different narratives about self-management of pain. And just to give you a little bit more of a sense of the approach that I'm using, people will be more familiar, I'm assuming, forgive the assumptions because we're not in a way able to have this discussion, people will be more familiar with more systematic reviews or narrative reviews. The approach I'm using is a hermeneutic literature review, which is borrowing from how humanities scholars look at texts. So they look at really old and ancient texts, and they interpret the meaning of what the person might have meant when they said it at that time. And I've applied that to self-management literature and texts, including documents and policy documents, and using what is called, a discourse analysis lens. So I'm paying attention to the language and paying attention to metaphors, buzzwords, narratives, and storylines to try and understand how self-management has been portrayed by different groups of people. And I'm also trying to understand the forms of knowledge that support these assumptions. And by that, I just mean, is it RCTs, randomized controlled trials, randomized trials, more experimental methods? Are we looking at narratives? Are we looking at more participant-led narratives in the literature? And so that is an ongoing process, and hopefully I'll be able to publish some of that soon. But what I'd like to do is really test some of my findings with you and see if they land and what people's thoughts are. So what I'm finding is that self-management, as a few different proponents have talked about, so Kate Lorig has talked about this herself and said, actually there's a problem. The way I think self-management is and the way other people are portraying it is all very different. And I know that the book by I'm going to say Dr. Rodham around self-management has also addressed some of these kind of issues. I'd encourage you to go out and read it if you have not, because it really captures some of these tensions really nicely. So really what I'm doing here is trying to theorize this issue of self-management and link it to sociological thinkers or sociological critiques, which I'm not going to go into detail here, but I'm going to give you some of the headlines. Try not to read ahead of me, because it'll happen very quickly. So self-management seems to be emerging as something that practitioners see as a desirable behavior. They want patients or people who go through self-management to emerge as being able to do things differently in their day-to-day lives, which somehow will have an impact on their lived experience of their condition, in this case, of chronic pain. It's also conveyed as an intervention, so really shorthand for what is essentially quite a complex intervention that is not really delivered the same way in different locations, but saying that self-management, I'm offering you self-management or I'm referring you to self-management, is sometimes a proxy measure for the very specific construct of a pain management program. So that seems to be coming through as well. It's also seen as the intended outcome for other complex interventions. So having gone through, say, a cognitive behavioral program or an ACT program, the outcome is seen as successful self-management. So the person coming out on the other side of this pipeline is doing self-management, whatever that is, and they're doing it very well. And that is reflected in the measures that we are collecting. So that's a different strand of information that I'm picking up on, is the type of outcomes. So our psychometric questionnaires are very much shorthand for self-management. So we might be talking about different constructs, self-efficacy. The self is present in a lot of these in the SF36. There's this sense of we're testing self-management, but that is not always explicit, but it's certainly an overarching narrative that is coming through. Self-management is also a practice that is done by people with pain. And in this sense, they are not describing it as self-management. They're just living their lives, and somehow in the process of living their lives are doing certain things that allow them to manage their condition in the time they're not with healthcare or social care practitioners, and they are doing different things. Now, what's really interesting for me is this practice may not always be sanctioned by healthcare professionals. So they might be doing things that are a bit kooky and wacky, but it works for them. And they also do something very clear, which is they don't tell us that they're doing it. So they're very happy to tell me in my research role, but they're not telling you the stuff that they're doing that they find very helpful. And a lot of this is in relation to alternative practitioners. And that seems to be a huge part of the system that is supporting this practice of self-management. Now, interestingly, when we look at the policy literature and also the academic literature, the idea of cost comes through very strongly. It's a cost containment measure. It's a cheaper version of things. You can do it in groups. It stops people being a burden on the health service. And this is very much related to the wider discourse on austerity, which is clearly there in policy explicitly, but it seems to have been adopted very much as a goal for self-management in whatever guise we're looking at. And this concept that it is not biomedicine, so when I'm talking to practitioners within my case study, they're describing self-management as all the other things you do that don't involve injections, medications, surgeries, or anything like that, which is, again, very different to how the people living with pain consider it, because for a lot of them, self-management involves their daily medication routine and how they manage the different doses, etc., to enable them to either push through to their daughter's wedding or cope with a flare-up. But this is definitely a practice that is not sanctioned by healthcare professionals. So generally, what I'd like to summarize with is that self-management is widely accepted as important, valid, and necessary. No one really is disputing that, but it is poorly described. The goal really is not here to come up with a definition, because that seems, what we're seeing here is a complex system. We're seeing complexity in action. And I think the term self-management has become like a shorthand and a way to deal with complexity, to kind of contain some of these more grand ideas of what's going on. Oh, I'm going backwards. So these assumptions that we have a consensus view when we're talking about self-management are not supported by empirical data. Instead, what we're seeing here is very much that this self-evident, received wisdom and taken for granted way that we in chronic pain talk about self-management fits the criteria for a discourse. So something that is persuasive, that is doing a lot more heavy work than we would assume when we look at just a term on its own. So moving away from the pain literature, which so far, I'm still in the process of summarizing some of the papers, there really isn't a lot of critical interrogation of self-management in the chronic pain literature. But here we're looking at some of the earlier authors who looked at self-management more broadly, and they have focused on trying to understand the socio-political dimensions and linking, like my own work is interested in doing, is linking what's happening in policy and what is happening in what is being pushed in practice. And what these authors found was early self-management was really couched as mutual aid, community, about social embeddedness and citizens emancipating themselves from services that were hard to access, and it was doing things outside the more dominant systems of the time. Then in the 1980s and 90s, they note that this cost-containing idea and the idea of self-monitoring has really become much more prominent. So they summarize that self-management has become and considered to be a cost-cutting mechanism. It is the domain of health experts and professionals rather than of citizens. And this idea of the self-management as emancipation and giving freedom to citizens has kind of lost it. It's kind of gone out of its way. And again, now drawing in literature more specifically in the health field, in this case, this is looking at the context of stroke care and rehabilitation. And I'm not going to go into a lot of detail about this paper, but they've done a similar thing to what I've done, which is they've looked at literature and secondary data from a different trial, and they've tried to understand it and theorize it using a power lens, for want of a better word. And what they found was that in the stroke care and rehabilitation context, self-management is highly nuanced, complex. It can fluctuate in its conceptualization depending on the structures, routines, and the individual. And they encourage healthcare professionals, policymakers, and commissioners to reflect on these complexities, to make transparent their assumptions, and to explicitly position their own practice accordingly. So just really like that phrasing, because I think there's much for us to think about in chronic pain management. And I'd just like to finish here by drawing from Chinua Achebe, who is a writer, a literary scholar, and from his book Things Fall Apart. And there he says, "There is no story that is not true, and the world has no end, and what is good among one people is an abomination with others." And this really strikes me about how different people are thinking about self-management and how that is leading to tensions and perhaps limiting what we can do. And I thought I'd leave us here with some questions. There are many, many questions. So really trying to think that does us having a default unchallenged view of self-management prevent other approaches from being explored, discussed, and practiced? And does this tendency of assuming personal responsibility and individual choice detract from these kind of wider ideas and thoughts around cultural and social systems, structures, and people's ability to do some of the work that we're asking them to do? Does the dominant way of self-management in chronic pain only give legitimacy to practitioners who do not deviate from this, I'm being very dramatic here, state-sponsored narrative of self-management as a, responsible citizen and a cost-containing measure, and therefore does that delegitimize other practitioners who have adopted different ways of thinking, perhaps, and of doing self-management that might be more acceptable to our patients and people with lived experience that is very different from our own? And then does this disenfranchise people who choose to self-manage in different ways apart from what is sanctioned? So leaving those questions deeply and very with bated breath, waiting for some questions, I'd like to thank my supervisors right now. So that is Sarah Shaw and Alan Silman at Oxford and Deborah Swinglehurst at Queen Mary. And I'm going to stop sharing.
That was brilliant. Thank you very much, Jackie. So I'm sure everybody is still slightly processing, because the concepts and the thoughts were coming thick and fast in that one, which was terrific. So by all means, get in the chat and begin to write down some questions. And maybe can I kick us off with one? I get to, because I'm the host. And I'm wondering, it's interesting, I wonder if we haven't been questioning this idea of self-management and not interrogating it in a sense, because we still see ourselves as slightly up against biomedicine. We see ourselves as less powerful, if you like, against the billions of pounds of the pharma companies. And that's why we've sort of been rather stridently banging on about it as a universally good thing and something we know how to do and is terribly good for everybody, because we've been trying to position ourselves against other powerful political forces. I don't know if you've got thoughts on that or anybody else.
I think for me, I hadn't, hands up, I hadn't even thought about political dimensions or professionalization issues. I just kind of thought self-management is what we do. It's what we do. It's great, isn't it? And I think as the field is being more critical and more questioning of more broadly about, for example, cognitive behavioral therapy or acceptance and commitment therapy and the role of movement. And I think we're starting to almost better dissect the interventions that we're offering in a bit more detail. I think now perhaps that's where there's space to suddenly go, but what is self-management? What do we mean by self-care? Why is self-care less interesting or good than self-management, in the same way that we're asking the questions about, I know psychologists talk a lot about process, still not clear, I understand that, but the idea that can we understand better what we're doing, but perhaps you're right, as a sense of there's a mystery to what we do, and if it's inscrutable from, I suppose, in terms of managers, and there's pressures on our services, if we're doing something, it's just self-management. You can't, maybe there's a hesitancy there, and it's our territory that perhaps is a separate domain from, biomedicine. And there's places obviously that do those two things together, but it's certainly not coming through that way in the academic literature.
Thank you. Right, we've got some interesting questions coming through, and I wonder if we can ask people to pose the question themselves. Amanda got in there first. Amanda, would you like to unmute yourself and pose your question to Jackie?
Yeah, hi Jackie. That was terrific.
Hi, Amanda.
I was wondering, when you talk to people who are kind of outside, as you said, outside the whole pain management program system, did they express suspicion about self-management being defined by healthcare professionals and not by, as it were, by their needs?
So it's almost absent in totality outside of the pain management programs and pain systems. So people talk about, in my head, the different components of it, but I I start off my interviews in the narrative sense. So I just ask people to talk. And then at the end, I ask, what does self-management mean to you? And really the stuff that comes up, that's where the stuff around, oh, that's just the NHS being cheap. That's just a way to keep us out. That, patients or people with lived experience are a bit like, I don't know what that means. That's just, I don't know what you mean. Of course I'm self-managing. What else am I going to do? So I think as a construct, it's very much, it's in policy, it's in research, and it's in practice. But outside of these fields, I suppose there's a bit more flexibility and curiosity about doing things differently, rather than that current, I can't even say defined because it's not defined, but maybe that currently assumed way of doing. So no suspicion. It's only when I raise it that people just go, oh, that's just that thing they do over there in the ivory towers.
Thank you, Amanda. Is there any follow-up to that one, or should we move to the next question?
That's fascinating. It sounds a bit like coping. Patients often used to say the same thing. You say you're going to tell me how to learn to cope, but I've been coping all the time. What else can I do?
Mm-hmm. And I think what's really striking was, because of this differential ways of understanding a concept, things for me that I think where it's important in practice is when we give patients the choice of coming into the service or opting into the intervention. If we're describing it in such vague terms, I wonder how much of that is pushing people away. They're just going, I just, that's not for me. The thing you're offering in your information sessions or in your literature just doesn't blend. And I think, yeah, interesting.
Thank you. Now, Betsan, was that a comment, Betsan, or would you like to pose that one as a question? Looks like a good question to me.
Yeah, it was a question really. Do you think self-management is a good term to use? For me personally, it implies something that's limiting to my life. Would it be better to use something like self-nurturing, so we're focusing on improving somebody's well-being?
I'm not sure I could say, just because there are other terms used interchangeably, particularly around self-care. And I know that in terms of some of the literature around well-being, that some of the well-being language is viewed suspiciously by different communities as being inaccessible and only for people who are wealthy or have time to do that nice stuff. So I'm not sure. I don't know that a different term would make a huge difference, but I think at least we should have that conversation of, what do you mean by self-management? Let's break it down. Do you mean, like with your interest, Betsy, so one of the things we're starting to see is people do all that other stuff. They go to their allotments and they spend, hours at a time with nature, and that's for them important. Like with the crafts and knitting community, they do that. Dancers, there's a lot of work looking at dance and movement and how that's interpreted. So maybe, yeah, I don't know I don't have an answer to that, but I think we should definitely explore different explanations.
Thank you. Now
Thank you.
The questions are slightly running away with me, and I'm trying to do a bit of a factor analysis in my head as I go through this, but I'm not sure I can do that. So I'll just turn to Shannon. Shannon, you had an interesting point from a pain advocacy point of view. Would you like to share that one?
Hi, sorry, my camera's not going to work very well. The internet isn't great today. But yeah, I think sometimes, like as been said before, you have to be careful about language. Just looking from our group and, parents dealing with different things, self-management, sometimes the holistic route, these kind of things can, if they haven't been managed well from the beginning, can become nearly almost like swear words to people. And I just feel like, you know, in a lot of cases where these like on the ground in the HSC, this team is being set up for the first time, there's very little public engagement as to what patients or end users actually require themselves. And like self-management, I feel like is a very difficult area because everybody's requirements are going to be different. So, you know, how do you come up with a model that's going to take all of that into effect? You know, and I suppose sometimes, you know, when I hear self-management or holistic, I nearly go, you know, people with chronic pain do very often have, like we all would ideally not prefer, you know, our children or ourselves or whatever to have to use drugs. But sometimes I think the feeling out there between, you know, in our group anyway, of all the, when I speak to people, is that sometimes when they hear this word, they feel that they're almost being fobbed off with physio and OT and whatever, and the underlying pain isn't being controlled in order for these other things to happen.
Yeah, absolutely. And again, I suppose taking a slight chicken way out of this is via my data. So I've spoken to GPs as well, who do the bulk of, this is where almost everyone has an interaction with their GP. And GPs are very clear, and some of the, what I'm identifying in some of my data is GPs feel like, I don't know what else to do. And they therefore feel that if they don't, you know, there's this worry about doing nothing. So if they do nothing, there's that sense of, well, I've come to the doctor's supposed to do something, but the doctor's going, I can't give you opioids anymore. So the tools that they have relied on are no longer helpful. So they're just going, I don't know what to do. I'm just going to send you off to someone else in the hope that that other person will have something else to offer. So yeah, I just think there is a sense, maybe there's a sense, this sense of the biomedical divide is happening in, you know, in practice, in pain management practice. We're very comfortable with, you know, biopsychosocial constructs and saying, yeah, the bio is not so prominent right now, but I'm not sure that that's the case for everyone. And other people continue to look for for biological cause. But I think listening to general practitioners, they're saying, I genuinely throwing their hands up going, you can come see me every week and I can check your prescription, but I don't have any other tools. Don't know if I answered that. But.
Well,
Yeah,
I think that picks up, sorry, yes. Go on.
Sorry. Just yeah, I agree. Like GPs play a very important role. Like, and we are blessed with my son that we have a very on board GP. But to be quite honest with you, like our experience is that a lot of GPs just go, this, especially with children, this is beyond my remit, and I'm not even prepared to go there. And I suppose that's where you then moved on to the teams. But you know, I think what we're experiencing anyway is that it's almost kind of like this model, and people are trying to be fit into this model when, you know, there's very little maneuverability for individualism within these models, even though they are taking more into account the biopsychological and social aspects. It's still very difficult, I suppose, to create guidelines for people to fit in, that all practitioners can use to fit people into these models, but then you know, still taking into account the individual aspects.
Right.
Thank you. Now I can see that Robin Horton has definitely reacted a couple of times to from the GP point of view, and Deepa has also pitched in there. Robin, is there anything you want to add? You may still be muted, Robin, if you're trying to say something, or that may just be no thank you, I don't want to add anything. All right, so we've possibly lost Robin there. Okay, let's come down then, because we've talked about fitting people into things and people having this very diverse and more widespread methods than they're usually in our philosophy anyway. Angela, you raised the issue that self-management can be indeed individualized within a broad toolkit of coping strategies. That seemed to speak to the kind of fitting in issue. Would you like to say anything about that? It's fine if you wouldn't.
This is Robin here. I think we're probably all having trouble. I was frantically trying to scramble my microphone on when it came.
You made it.
I did. Yeah, I mean, perhaps I can comment on that as well. I mean, in terms of sort of fitting in, I thought it was a very interesting point that was made in the very interesting presentation about there's a particular type of person, you know, both probably age, colour, economic background, everything else that would generally choose to participate in a group setting. I thought that was a point excellently made. And as the point I sort of made in the chat, which a couple of other people picked up on, I think from the GP point of view, you know, if you've got somebody who's had a lot of interventions, you know, over the years, who's got a persistent chronic pain problem that's presented over many years, you know, that they really are at their wits' end. You know, I do desperately feel for them because, you know, they feel like they haven't got a lot of things in their toolkit to offer people. And I think, you know, that's really the difference between a pain management program and a self-managed program. You know, we're very lucky here because we have the BCPS, you know, as a local, although it's a national thing, you know, a lot of local people can take advantage of it without having to travel very far. And that is an entirely different approach to a self-managed. It's almost the opposite, you know, sort of thing. It's almost the complete opposite of that, really.
Yeah, and I think what's been striking for me is I think practitioners are doing themselves a disservice by not describing what they do other than as self-management, because people understand they do the work all the time. It's not easy having a chronic illness or chronic pain. So when we're saying the big team at Bath is going to offer you self-management, it's like, what? You know, are we doing a disservice by not really describing our complex interventions so that the GP has something to then say, actually, the big team at Bath, what they do is A, B, C, D, E, and it's not fobbing you off. It's actually a valued service. So maybe, like Betson said, maybe the language is important here because it's conflated at the moment.
Yeah, no, I think the language is very important. I think she was absolutely right. And I think societally, you know, people can get the wrong end of the stick, and a message can become, you know, a phrase or a message can be something that people just get turned off to, and maybe self-management, you know, has got a bad rap, you know, and people are just turned off the concept. And I think if you, as you say, if you broke it down into actually what it was offering, I think people would understand it better.
So we're running to a close. There's one quite juicy question in here from Sarah Wilson, if that's all right, about self-management potentially as a critical or blaming concept. Sarah, would you like to bring forward your question?
Hello, Jackie. I was just thinking, because often when I meet patients, they kind of go, oh, I'm here because I need to self-manage, and self-management and doing something about your pain almost become kind of synonymous, and you should be doing something better about your pain, then your life will improve in some way, or potentially then you'll stop coming to see me or other people and you'll cost us less. And I think I meet a lot of people who often have seen a lot of professionals on their journey to treatment, and they can kind of come with this this sense of I haven't done that, because implying that people should self-manage, we're implying that maybe they're not, and that therefore bad patient. And I think I just wondered whether that's come through in kind of your conversations with people and the discussions you're having, because I think it's the thing that clinically makes me quite sad.
Yeah, it's been a very discombobulating time, because obviously as a practitioner I'm going, well, you don't know what I'm talking about, do you? And I'm finding it quite hard to separate my clinical staff. I'm actually really annoying to be around in clinic, because I'm going, whoa, what do you mean by that? Mainly because the people who are living with pain are living with pain across a huge spectrum. So there are those who are living well without instruction. They've not been told what to do. They may have met, say, for example, a rheumatologist who suggested to them, your condition is yours for life. We can't do much about it. The best thing I suggest is that you keep walking every day. And they literally take that and they go with it for 12 years and they walk every day, and that's their self-management. But then I suppose the people on the end of spectrum who are really struggling, it seems to be, I'm sure you know, like really bundled, this idea of a valid explanation for why they feel the way they feel. And it seems to me so far that on people's narratives, until they hear an explanation that makes sense, whoever it comes from, everything else is kind of filtered through that lens of, you don't believe me, and you know, we live in society, therefore what, you know, the usual, what's wrong with me? And if you're saying it's all about self-management, I've clearly been a bad patient. And this is, I'm getting a lot of, this is where you get all the secretive stuff, the practices they'll tell me about, but they won't tell the healthcare professional about, because they've already picked up on, well, you don't like that stuff when I tell you, so I'm just not going to tell you. That sometimes I take a day out and I stay in bed, and it's great. And this is not all professionals these days, I have to say that a lot. But you know, that sense of the opioids, I think, is a huge issue. People are feeling a little bit frightened and threatened, and also like I mentioned, the so-called alternative practices are, people do it. They're doing the stuff. They are going on the internet, and so many people are on the turmeric, and you know, and they're visiting. Oh, I went to see my NHS physio, who just fobbed me off. Therefore, I've gathered up some resources, and I see this other person down the road from me, and they do this other stuff. I've totally not answered your question, but just, yeah, rambling.
Well, your rambling is very high quality rambling. I think everybody will agree, Jackie. So what we're going to do is, because we have sort of reached our time, and thank you for the people who are putting kind and positive comments in the chat box. So we're going to draw this one to a close. Okay. So I just want to say thank you to Jackie. It was terrific. And the idea of engaging other forms of knowledge and doing policy analysis and things like that has been mind-blowing to my very quantitative brain, and most stimulating. So thank you for speaking to us, and thank you for making it so interesting and engaging. So everybody else, thank you for the comments in the chat box. That's lovely. So I will email everybody after this, all of the attendees, just with some other bits and bobs if you want to stay in touch about Pain Forum, or if you want to get the link to the recording, which won't be widely available on YouTube. You won't be able to search for it or anything, but we'll put it on the YouTube channel with a private link for anybody who's got the private link for a couple of weeks, just in case anybody wants to catch up on that, or anybody missed it. And that will all come in the follow-up email after this. So equally, you'll be able to get back to me on the email if you want to, if you're not that social media keen and you'd rather have an alert in your inbox, then we can email you guys to keep you abreast of future events. So thank you all for coming. Thank you for some lovely questions and for some lovely comments in the chat box. Thank you to Jackie once again, and I will draw us to a close. Okay. Thank you very much, everybody. Good evening.
Good evening. Bye.